Good morning, good afternoon, and good evening, everyone. On behalf of IAMRA, it's my pleasure to welcome you to today's webinar. Before we begin, I'd like to thank you all for taking the time to join us from different parts of the world. We are delighted to have regulators, healthcare professionals, and colleagues from across our international community with us today. My name is Muhannad Almughthim. I serve as a board member of the International Association of Medical Regulatory Authority, IAMRA, and I am the General Manager of the Standards Department at Saudi Commission for Health Specialty. It's my pleasure to be your facilitator for today's webinar, and I'm delighted to help guide the conversation on today. For those who may joining us for the first time in IAMRA webinar, IAMRA is a global membership organization dedicated to advancing effective medical regulation. Through collaboration, education, research, and the sharing of best practices, we work together to strengthen medical regulation and ultimately protect patients and the public. Today's webinar reflects that commitment. Artificial intelligence is rapidly changing healthcare around the world. And while AI offers opportunity to improve patient care, it also presents an important question about professional responsibility, accountability, education, and public trust. So today's discussion is therefore especially timely as we explore how doctors understand their professional responsibility when using AI system and what these findings may mean for medical regulators around the world. Before we introducing the speakers, I've just a few housekeeping announcements before we begin. If possible, we encourage everyone to keep your cameras on during this session as it helps create a more engaging discussion. Participant microphones have been muted during the presentation portion of this session, as you know. Following today's presentation, we'll have time for discussion, and I encourage everyone to participate. If you'd like to ask a question, please use the raise hand feature, and we will invite you to unmute when appropriate. You are also welcome to post question in the chat throughout the webinar, and we will do our best to address as many as time permits. Finally, following our today's session, you will receive a short evaluation survey. We'd be grateful if you could take a few moments to complete it, as your feedback helps us continue improving our educational programs. So it's time for me to introduce today's speaker. It's my pleasure to introduce our first speaker, who's Francis Leng, Senior Research and Evaluation Lead at the General Medical Council in the United Kingdom. Francis has led this important research carried out in collaboration with the Allen Turning Institutes, examining doctors' understanding of their professional responsibility when using artificial intelligence systems. And today he will share the key findings from this work. Francis is joined by his colleagues, David Winks, a regulation policy manager at the General Medical Council in the United Kingdom. David works alongside Francis and will help set out the policy context in the UK, including the work of the National Commission into the regulation for AI in healthcare. Joining Francis and David is our reactor, Neeraj Ramesh Mahboobani, who's a clinical assistant professor in the Department of Imaging and Interventional Radiology at the Chinese University of Hong Kong. Following the presentation, Dr. Mahboobani will offer his reflection and perspective, drawing on the experience of doctor, medical educators, and the Hong Kong Academy of Medicine. Francis and David, thank you both very much for joining us today. The floor is yours.
Thank you, Muhannad. Thanks for having me. Yeah, as Muhannad said, I'm here to talk to you about some research we're involved with. It was a couple of years back now, exploring doctors' understanding of their professional responsibilities when using artificial intelligence in their practice. So I'm Francis. I'm part of the research team at the General Medical Council, which is the independent regulator of doctors, physician associates, and anaesthesia associates here in the UK. And our role as a professional regulator involves setting standards, maintaining the register, and also taking action where concerns are raised. So just moving us on to talk a little bit about the background and objectives of this project. So the Allen Turing Institute approached the GMC about collaborating on a research project to explore doctors' views and experiences of using different types of AI systems in their practice. AI is a very hot topic in the GMC, as I'm sure it is for many others on this call, both in terms of how we adopt AI to support our regulatory functions, but also critically how our registrants are using AI in their practice. And it raises critical questions from the professional regulator perspective around things like professional judgment, consent, and accountability. I think it's important to say we're not responsible for regulating the technologies themselves. That's the Medical and Healthcare Products Regulatory Agency here in the UK, but we are responsible for regulating and setting the standards registrants are expected to uphold when they're using these technologies. And you can see on the screen here a learning resource we produced to help answer queries about how registrants should use our standards or should apply our standards when using these technologies. So we'll just move us on to the next slide, please. So a little bit about how we defined AI in this research. Yeah, I mean, it's a complex topic, and full disclosure, I am in no way an expert on it, but I think it's relatively uncontroversial to say that there's no kind of single universally accepted definition of AI. And here we built on an NHS report to define AI as automatic or computerized systems that are trying to emulate some type of human intelligence or support some kind of intelligent decision-making or thought process. And within this research, we really focused on the use of 3 types of AI systems. So diagnostic and decision support systems, which aid the use of multimedia data by, for example, identifying the presence of a tumor on an MRI scan, as well as tools for decision support, risk stratification, predicting outcomes. The second type of AI was system efficiency systems. So these try to predict missed appointments, to maximize staffing and resource allocations or optimize care pathways. And finally, generative systems. So a key example here being ChatGPT. And these create text or images on doctors' behalf, often on the basis of specific prompts, and these can help with things like writing out patient notes and things like that. So next slide, please. So a little bit on the methods. So the first stage of the research involved an online survey of just under 1,000 doctors practicing in the UK. We asked a representative sample of doctors to take part, and we encouraged all doctors to complete it, whether or not they were using AI in their practice at the moment. The survey covered their experiences of using these different types of AI systems, their wider perceptions on the use of AI in healthcare, and also critically their understanding of professional responsibilities when using AI. We then commissioned 17 follow-up qualitative kind of depth interviews with AI users to allow us to explore some of these survey themes in greater depth. So next slide, please. So after that background and methods, let's jump into some of the findings from the research. So within the survey, just under 1 in 3 reported that they were using some type of AI in the past 12 months, with similar proportions, around 16% having used diagnostic and decision support systems and generative AI systems, with a lower proportion, around 7%, having used system efficiency systems. The survey found that younger doctors and male doctors were more likely to be using AI, particularly generative AI at this point. And doctors working in radiology or medical specialties were also more likely to be using AI, particularly diagnostic and decision support systems. Diagnostic and decision support systems were being used kind of more frequently at the time than generative AI, with around 38% using it every day compared to just 8% of generative AI users. But generative AI was being used quite frequently still, with just under half using it at least once a week. I think what this shows is that, you know, at the time of this survey, AI was already embedded in the working life of a substantial number of doctors, but at the time, the vast majority was still not making any use of AI. But I think it is important to flag that things are going to have moved on quite a bit from this point in time. And we did find in the most recent national training survey that almost 3/4 of GP trainees reported having used AI in their training. So I guess that gives you a sense of the scale of usage and how that might have moved since then. So next slide, please. The interviews, they allowed us to delve a little bit more into doctors' understanding and use of AI. And I think the first and really important and interesting finding here is that there was definitely some uncertainty amongst those interviewed about whether the tools they were using would even be classed as AI or whether they were using AI, and quite a few pointed to the fact that they'd long been using algorithms in their practice to support decision making. And most were also using a kind of combination of different types of AI systems. Generative AI was being used for several purposes, including administrative support, like writing up patient notes, education and research, but also was being used in some cases to aid diagnosis. For diagnostic and decision support systems, AI and algorithms are being integrated into triage and patient management tools to help prioritize which patients to see, suggest diagnostic tests, and optimize care pathways. And when it came to secondary care, the interviews identified some kind of specific examples of how AI has been used to assist complex diagnosis. Some examples given here were for assessing stroke patients, for administering local anesthesia, and also delineating organs in radiology. But this is in no way a kind of exhaustive list, just examples that were raised by those in the interviews. So next slide, please. So for those in the survey that were using AI, we asked them some questions about their experiences of using the type of system they were most frequently working with. Encouragingly, most doctors reported being confident using the system and that the outputs of the systems were clear and understandable. And this was the case for both diagnostic and decision support systems, as well as generative AI. However, while 7 in 10 reported that they felt that they could explain the outputs of a diagnostic and decision support system to patients, this was much lower for generative AI, being around 1 in 3. Next slide, please. So for diagnostic and decision support systems, around half agreed that they'd had sufficient training on the systems and that they felt kind of confident that they understand how to raise questions about the system, but this was much lower for generative AI. So you can see here, only 1 in 5 agreed that they understand how to raise concerns, and only 15% that they'd received sufficient training. But the interviews did kind of reveal or show that this was largely due to the fact probably that the generative AI systems were more early adopters that was self-taught and self-learning through trial and error, as opposed to diagnostic decision support systems, which was more implemented at an organizational scale, and doctors had received more formal training. Next slide, please. So doctors were broadly positive about the impact of these AI systems on their practice. 62% agreed that diagnostic and decision support systems had improved their clinical decision making. This was much lower for generative AI, around 1 in 5, but this probably reflects the way that generative AI is actually being used. 62% did agree that generative AI increased their productivity. This was a little bit more mixed for diagnostic and decision support systems, but still, just under a half agreed that increased their productivity as well. In the interviews, the doctors, they did feel that the strongest expected and experienced benefit of AI was improved efficiency. Using AI effectively to free up or make better use of doctors' time and free up resources that could be dedicated towards patient care. But they were keen to stress as well, this wasn't always the case. They did flag that when they they were concerned about the accuracy of the AI systems, that they could end up spending more time checking the outputs. So this wasn't always the case, this benefit. AI systems also provide a valuable safety net, particularly given the resource-pressured environment that doctors are in. Further benefits include reducing risk of human error and bias, and also the ability of AI to draw on pretty much limitless information compared to a single individual. So next slide, please. So we asked a set of questions about doctors' perceptions of the current and potential use of AI, both in their area of practice and the wider healthcare system. And the picture was somewhat mixed here. Around half were optimistic about the integration of AI systems in healthcare, but most felt that AI opportunities weren't really being fully explored at this time. I think quite interestingly, maybe surprisingly, only 15% were worried about the impact of AI on their job security. Next slide, please. So yeah, then the survey went on to look at doctors' understanding of their professional responsibilities when they're making decisions with AI, and there was certainly more uncertainty and concern here. 44% agreed that they understand the risks of AI in their area of practice, and only 30% agree that they understand who is responsible if a decision is made incorrectly involving an AI system. Perhaps unsurprisingly, this was even lower for those that weren't currently using AI. And I think, concerningly, only 12% agreed that they'd had sufficient training to understand their professional responsibilities when using an AI system. Next slide, please. So despite this, only a quarter in the survey were worried about AI eroding their professional autonomy, and the majority did feel confident overriding the recommendations of AI systems where it was needed. Next slide, please. So to explore this in a slightly different way, we presented doctors in the survey with the following scenario. So I'll just read it out for you here. You are using an AI clinical decision support system which recommends treatment options for individual patients. You disagree with the recommendation that is given by the system. How would you proceed? So I think the first interesting result is that 1 in 10, 12% stated that they don't know how they would proceed. But for doctors that were able to provide a response here, they mainly identified ways they would seek further information to try and explain the differences between their opinion and the recommendation of the AI, whether that was discussing it with colleagues, checking internal or external guidance, or checking the data and rerunning the system. Ultimately, though, almost all would lean towards their own professional judgment rather than following the recommendation of the AI. So next slide, please. So the doctors in the interviews, they all felt fairly confident that they could manage the risks when using AI, but they were able to identify a number of potential areas of risks that professionals should be considering when they're using these systems. So the first area of risk is that the data that the AI systems is based on may be false or biased, and this kind of highlights the need for checking the sources. Doctors did acknowledge that the outputs of AI could be prone to error or lack of sensitivity. An example given here was image classification tools for melanoma not being sufficiently trained on images of people with different skin types. Another area of risk was lack of clarity and transparency about how these systems are working or where the weaknesses might be. And some were concerned that this kind of black box could lead to some doctors taking the outputs of these systems at face value. When it came to consent, this didn't really come up spontaneously, which was interesting in itself, but when prompted, doctors did feel that while patients need to be aware of how their data has been processed, they didn't necessarily feel that patients needed detailed knowledge of how these systems were working, or in fact that AI was involved in the decision at all. And then finally, another area of potential risk was over-reliance, a potential over-reliance of AI, the future erosion of judgment and maybe de-skilling of doctors. This was a bit mixed though. Some others flagged that similar arguments have been made about almost any new diagnostic technology that's been brought in the past as well. So that wasn't universal really. And then when we look at understanding of professional responsibilities, I think almost universally in the interviews, they all saw AI as an assistive tool that they ultimately retain responsibility for decisions. Some felt that those responsible for kind of procuring and developing the systems should be taking accountability as well, but I would say that there was a kind of lack of faith that that would be the case in practice. Reinforcing the survey findings, almost all the doctors in the interviews said that while they would take AI into consideration, the recommendation of the AI into consideration, they all felt confident overriding it where necessary, and many said that they were already doing this regularly in their practice. But it did come out of the interviews that there is this question of how AI evolves in the future, and as it becomes more accurate, more embedded in practice, the question of responsibility and liability will become less clear-cut. So next slide, please. So just talking about the difference in views and experiences across the workforce when it came to the survey results, AI users and male doctors tended to be more positive about AI, more confident about using it, and less concerned about the potential impacts on their practice. Interestingly, UK qualified doctors tended to report being more uncertain about risks and their professional responsibilities compared to international medical graduates. There was actually a bit of a mixed pattern when it comes to age. So older doctors were less likely to agree that the outputs of AI systems were clear and understandable, but they were more likely to agree that they've been consulted and received sufficient training on the system. Next slide, please. Finally, I'm just going to touch on education and training and the role of the regulator. So I think the first thing to flag is that within the interviews, the doctors definitely felt that the training needed to be dependent on the role and the specialty, but they were able to identify 3 broad areas of education and training need. So firstly, basic education on AI to kind of promote a broad understanding of AI and its impact on doctors' practice. Then for doctors that are required to use particular systems, they would need specific training on how those systems work, the data that's been inputted and how to interpret the outputs. And then finally, there was felt to be a need for kind of broad training on ethics and data protection, specifically related to consent and the level of information that patients need to be provided with. And many did feel that there was a role for regulators, whether that's the GMC or other regulators like the MHRA, in clarifying responsibilities when it comes to using AI, and also for helping doctors to understand and navigate the risks associated with particular systems. So next slide, please. So yeah, just to wrap this up a little bit and put it into context, I think there are some important kind of limitations and considerations of this research is important to be aware of. We undertook a kind of representative sample of doctors, but the interviews that we undertook added a lot of colour and depth to these findings, but this was undertaken with quite a small number of doctors, and these tend to be at the time early AI adopters, quite enthusiastic early AI adopters. The second thing to make you aware of, here we're looking at mainly at broad use of AI across the workforce, and I do think this general workforce perspective is helpful, but it clearly needs to be built on with more specialty specific insights. And finally, as I've mentioned, the rapid pace of change in this area, some things are definitely going to have moved on since this research was undertaken, particularly around how AI is being used, which is constantly evolving. Despite this, I think there's some very important findings here that remain relevant for regulators today, and I'm going to pass over to David now, my colleague in our regulation policy team. He's going to be able to provide you with a little bit more of the policy context and also tell you about how we use evidence like this to inform how the GMC responds in this kind of ever increasingly AI-enabled healthcare system. So I'll pass over to David now. Thank you.
Thanks very much, Francis. So can we just move on to the next slide, please? And then there we go. Thank you very much. Hi everyone. As Francis has said, just going to provide just a few brief slides just to set out some of the wider policy context within the UK. So just starting with this first point, that AI, as I'm sure it is true for many other countries, is a big priority for the government, and the government have been placing quite an emphasis on the potential for AI to support the NHS. So there is a 10-year plan for the NHS, which sets out the kind of some of the aspirations there, including it talks about making AI every nurse's and doctor's trusted assistant to help save them time and support them in decision making. There are some of the benefits of AI, such as faster diagnosis or enhanced clinical efficiency, are being cited, and they're also being set against a backdrop of long waiting times, widening inequalities, and workforce pressures. So AI is being seen as one of the potential opportunities to help with some of those things. But of course, there's also that need to take into account the wider considerations and potential risks, and in particular, there's sort of novel challenges that are presented by the characteristics of AI, which its autonomy or its potential autonomy, in the sense that it's potential there for decisions to be made without the ongoing control of a human, and also its adaptability, in the sense that the logic behind the outputs can often be quite hard to explain. So this is something from a regulatory perspective we need to consider. Next slide, please. So Francis has obviously set out the research from the perspective of professionals. We thought it would just be helpful as well just to provide some research findings relating to public attitudes in the UK. So this isn't research that the GMC have done. This slide just sets out some findings from research carried out by the Health Foundation, which is a think tank, by King's Health Partners, which is an academic health science centre in the UK. There's quite a few points here on the slides, but just to pick out a few. Quite an interesting point here about staff in the NHS being more positive about technology and AI in healthcare than the public. So there's sort of kind of a stark figure there of 80% of staff supporting the use of AI for patient care compared to 54% of the public. So there's a sort of noticeable degree of caution there, and that's also seen in the chart at the top right of the slide, which shows that the public is more cautious about the use of AI than NHS staff. The other point just to pull out is demographic differences in attitudes to technology and AI. So tends to be, I think, more caution or less positivity from women, from younger people, and from people in more socio-economically disadvantaged groups. And then finally, point here, and this relates, I think, to the chart at the bottom right of the slide, which is just around who the public would look to hold account if there was an issue that was missed by AI, and that they would hold doctors and other healthcare staff most responsible. So I think that's, again, just an interesting point to pick out there. Next slide, please. So one of the big, or the big initiative that's happening at the moment in the UK is the National Commission into the Regulation of AI in Healthcare. So this is a non-statutory advisory body that's been established by the UK's Medicines and Healthcare Products Regulatory Agency, which is an agency of government which is responsible for regulating medical devices. And the Commission has been set up to provide recommendations for a new regulatory framework for the use of AI in healthcare. And it's bringing together global AI leaders, clinicians, and regulators as it does that. The GMC, we've been contributing to that work as a member of one of the working groups that the Commission has. So the Commission, they have published some findings from some of the engagement that they've done. So there's a call for evidence, and also more general research and engagement. We've provided a couple of links there to those in case they're of interest. And then now waiting to see the recommendations. This is due to be published later this year. Next slide, please. So this is just the final one for me. This is just intended just to illustrate some of the questions that the use of AI raises for us as a professional regulator, and be interesting to to see if these resonate with organisations around the world. So this is in relation to the various functions that the GMC has. So, including how do our ethical standards apply when professionals are using AI? Questions about, if a patient were to suffer harm following treatment involving the use of AI, where does accountability lie there? How does the use of AI impact upon education and training? How does it potentially, change the skills or the education that professionals require? And then finally, a set of questions about impact on public and professional confidence. So, for example, what do healthcare professionals and the public need to retain trust in the use of AI, and how might it impact patient expectations? So these are, very much live questions, which I know a lot of different organisations will be working through and giving thought to at the moment. Next slide. Thank you. And so that brings us to the end of the presentation. We just included a couple of screenshots of the research that Francis has been speaking to, and obviously very happy to take any questions or field any queries that anyone has. And with that, I think I'll hand back to Muhannad.
Thank you, Francis and David, for setting both the research findings and policy context so clearly. Thank you so much. Before we open the floor, I'd like to turn to our reactor, Neeraj Mahboobani. So, Neeraj, from your perspectives, or from the perspective of doctors and medical educators in Hong Kong, how do these findings look to you? Where do they resonate, and where might be the picture is different in your jurisdiction?
Thank you, Muhannad. First of all, very nice presentation, Francis and David. Even though the surveys that you guys conducted or your groups conducted in the UK were 2.5 years ago, I think a lot of the trends and patterns I would believe would still hold true today as well. Though there might be certain differences in certain answers, which perhaps, for example, I would expect maybe now if we go back and ask the question of the percentage of survey respondents who have used AI, I think the number might be larger, and there might be other questions which I think the answers may be slightly different. So there are a couple of things which came out from what you guys have shared, and I would like to touch on a couple of things which I think would be important for the audience. We touched on productivity and confidence in decision-making when we talked about DDS, which is Decision and Diagnostic Support Systems, and also generative AI. So for the interest of the audience, what I want to bring out over here is these are two fundamentally different AIs that we can use in the healthcare. So DDS systems are what we call narrow AI or interpretative AI, where they are trying to perform a task which requires some degree of clinical acuity or acumen from the background. So how these models are trained and how these models are developed would be very different to a very large general purpose AI tool like ChatGPT. So just for example, DDS systems would be on my radiology side, for example, on a chest radiograph, is there a pneumothorax? Or on a CT brain, if there is a bleed or a hemorrhage or a tumor. So when these tools have been designed well and created well, they can actually facilitate the process, the clinical evaluation and reporting of a radiologist, for example, and therefore they would find that it will enhance their decision making. Now, when we come to generative AI strength lies in actually processing vast amounts of information. And you have large documents, 500-page document, they can actually process things a lot faster, or they can generate summaries for you a lot faster. There are people, mainly in the public, who do try to use generative AI to ask clinical questions, or to ask, as I would mention earlier, the narrow AI or the DDS type of questions. And what I want to bring that to attention is that till today, the major regulatory bodies around the world, such as the FDA or the CE, there's no generative AI tool which has been cleared for use in the medical spectrum. And therefore, from the generative AI perspective, it enhances efficiency if we look at the responses that we saw earlier, but it does create a lot of uncertainty as to whether it's accurate when answering those DDS type of questions. So this is what I want to bring out first for the audience is DDS systems are designed and built differently versus generative AI systems. And we need to know when to use which system for the task that we're trying to do. So because they are designed differently. So the second question came about as to a lot of people being optimistic about AI, but they all agree, a majority agree, that it's not being used to the scale where one would expect today about AI in healthcare. And I think that pattern or that trend will still hold true as well. And there are certain reasons behind this. Is because hospitals, healthcare institutions, they operate in very closed systems. We use our own softwares. We are very concerned about data security, patient confidentiality, because these are very personal, important information. And then there are a lot of learning curves when you want to bring to use AI inside. So you have a lot of tools to choose from, and then you have to integrate it into your closed systems. There's an integration process involved. And then when you want to deploy it, you have to have the training provided to your staff as well. And then you have to look at it from a value point of perspective. The cost of deploying that AI, is it actually adding ROI to the healthcare organization? Is it actually making the doctors faster and more efficient, or is it actually slowing them down? So when I've spoken in previous events, I like to give the example of electric vehicles for the general broader population to understand. The electric vehicles came about because of the technology that was developed to create electric batteries compared to conventional batteries, right? So we have a lot of very good models in healthcare, which are like very good batteries. But what the healthcare industry actually needs is to identify how to get through the implementation sciences of putting 4 doors, 4 wheels, a chassis, a bonnet to create the car. Because what the healthcare profession actually needs is the car, not a great battery. So what we have today in medicine, we have a lot of great batteries, which are great models, great tools to use. But the challenge in healthcare, which is more nuanced compared and more sophisticated compared to other industries in the world, such as the finance industry or the legal industry, is how to implement them. And that is where we are in the healthcare stage. So therefore, there is a lot of optimism, but why we're not seeing so much of it on the ground? Because we're now navigating the implementation science phase of bringing these great technologies in. The third thing that came out is who is responsible if AI is being used. So when we use AI, we've mentioned the word augment or assist clinicians. And then, of course, there is the notion that is being discussed a lot in the world today is autonomous AI. So right now in healthcare, we're still mainly at the phase of AI as an assistant or AI as an augmentator of what we do. That means there is a human, a clinician in the loop. So no matter whether the clinician uses or does not use AI, the responsibility falls onto the clinician for every clinical outcome that is there for the patient. When we come to the phase of autonomous AI, I think there might be some more broader discussion about that. But as of today in healthcare, we're still at the phase of AI as an assistant or AI as an augmentator. There is a human, a clinician in the loop. And whether the AI is wrong or right, the responsibility of the clinical outcome ultimately lies on the doctor. So the other thing we talked about is many survey respondents feeling they're not trained or they don't have adequate training. And that has now, what I want to highlight is after the survey being 2.5 years ago and what has happened in the past 2.5 years with further development of models and, multiple models coming out, the training of doctors in AI is of utmost importance. And here I would like to share with our audience of what we're doing in Hong Kong. We recognize AI is going to come into the healthcare industry and is not going to particularly affect just the younger grooming doctors or the more experienced. It's going to come and it's going to affect everyone as a whole. So we have 2 medical schools in Hong Kong, and both medical schools are now devising AI fundamental curriculums for at least undergraduates to understand basics of AI. Me on the Academy of Medicine, so the Hong Kong Academy of Medicine is the overarching professional development body, under which we have 15 colleges, such as the College of Surgeons, College of Orthopedic Surgeons, we have College of Physicians, Radiology, etc. And we are in charge of the continuous medical education, etc. for our postgraduates. We have devised a AI literacy course, which we have now putting out for all postgraduates, who are in various specialties, for them to have an understanding. First of all, why is AI evolving now? Is because we have vast amounts of data. We have hardware infrastructure to process this data with GPU technologies and semiconductor technologies. Then we talk about the different types of networks or how AI works. Actually, it's a lot of neural networks. Basically, neural networks means is AI software or software which are able to process the information just like how humans are able to do it. Then we talk about the importance of what data is given into the AI models, and that will determine what kind of quality or strength of the AI model will come. We have to emphasize security. So these are the different things that we talk about in our AI course for postgraduates. And the way we're doing it is because it's very hard to bring together so many people, we're designing it as an online asynchronous system. So we've just started creating this course, and it's open to all postgraduates in healthcare professionals in Hong Kong. And we're trying to see the response, and our direction will be to actually kind of make this a kind of a mandatory course as part of continuous medical education for postgraduates down the line. At the same time, the undergraduate medical schools are also devising AI curriculum. So we understand AI is going to come into our workforce, into our field, and we want to make sure everyone across the generations is prepared for it. So then the next comes to the point of transparency. We did touch about transparency. Now, the way I think of it, I think I would like to make it clear that this is my personal thoughts, and maybe a couple of people who I have great conversations at length with about AI, is we might start seeing blanket disclaimers for patients who come into hospitals, just like how we have the parking lot or the hospitals under CCTV monitoring. So it's a blanket disclaimer that everyone knows that whatever is happening in the corridors, there is a camera that's watching. So they will probably become a phase where there will be blanket disclaimers that, oh, we use AI systems in our hospitals, and if you have any queries or concerns, then please feel free to reach out to your clinician or your healthcare provider for them to elaborate. Because AI is there at many different levels. It can be there in the clinical decision-making process. It can be there in the documentation process. It can be there in your insurance and billing process. It'll be very hard to speak to patients at every stage of the way and tell them what the AI is doing, because then that will eventually lead to a big slowdown of our healthcare provision rather than making it more efficient. But on the clinical decision side, I think the way we've seen it is there's going to be two levels of transparency or consent that we have to approach. There are AI guidance systems which help the doctor make a decision, and then the doctor is the capability or has a training to either accept or disregard that. For example, there can be ECGs that are done, and many times when you do an automatic ECG, there is a guidance as to whether the rhythm is a normal rhythm or whether it's an abnormal rhythm, whether it's a high heart rate or low heart rate. So these little kinds of guidances that are there for the healthcare providers. So simple decision DDS systems where the doctors are using it to help them facilitate the management, we may not really need to be explicit with the patients that we're using AI. But the way AI is now developing is it's actually able to process large amounts of data and there's a lot of development towards giving suggestions as to whether a patient with a certain disease and a certain family history should undergo, for example, surgery or should undergo radiotherapy. So what I'm trying to bring about here is there is a judgment that's involved. And I think when we come to that stage of using AI, where there's a judgment or treatment decision to be made for the patient, we will have to have explicit consent of the patient. If I can again go back and give another analogy, which may be a bit more general, is when for example, accountants. AI, which are using DDS systems where I feel we don't need to ask or explicitly explain to the patient AI being used, is like an accountant using a calculator to summate the numbers he's put across for a company or for an institution. But then if you're using a judgment level for an accountant to decide whether there's some things which don't line up, maybe if there's some transactions which are maybe fraudulent, there's a judgment that's involved. And for that, when we use AI down the line as healthcare providers, we have to have explicit consent, because that might be different from what one doctor may say, a second doctor may say, and AI may have a third opinion. So that's my thoughts on transparency. There may be blanket disclaimers as technology evolves and AI makes its way into healthcare organizations and healthcare institutions. We don't have to have explicit consent for every AI that we use, because that'll be very time consuming. But if there is AI where there is a judgment, a very important decision that needs to be made for the patient, then we have to be explicit about what the AI is saying and what the doctor feels for the patient, and then leave that decision to the patient to decide as to how they want to proceed with their healthcare. So I just want to touch on these few topics about, for example, DDS systems versus Gen AI systems. Just touch on the challenges as to why we're not seeing AI implemented to the extent one would think that would be there in the healthcare system. What we need to do to enhance training, and and share the example of Hong Kong, and also touch on a little bit about transparency and consent, which we did cover in the survey. And I think I will leave it at that, Muhannad. Thank you.
Thank you very much, Neeraj, for the thoughtful reflections. I think you have highlighted not only the opportunities AI present for healthcare, but also important questions for regulator, educators, and the health professional in general. I'd like now to open the discussion. I'd really encourage colleagues to share their own experiences as a regulator, and I'm interested in hearing whether today's finding resonate with what you're seeing in your own jurisdiction or not. Please, if anyone would like to share, just use the raise hand feature. And before going to that, I'd like to come back to Francis. You have mentioned something about the different type of AI systems through the your surveys. Was it difficult for people in general to understand the differences between those different AI systems?
Yeah, I think it was. I think it probably, in hindsight, should have been something that we covered more in the survey, i.e., kind of doctors' understanding of what AI systems are. The approach we took is that we took a definition within the NHS report, and then we provided these examples, these kind of use cases. But I do think that what we found through the interviews is that, as I said in the presentation, some doctors weren't fully certain whether the tools they were using would be classed as AI or whether they were using AI, and also that some felt like there was quite a lot of overlap in terms of use cases. I think Neeraj just mentioned there that you have DDS systems for clinical decision making, but actually some were using generative AI to support with diagnosis in some ways. So I think it's difficult in surveys do you go down the route of defining like the type of the AI system, or do you define the use case of it in practice? And I think probably the latter is easier for most doctors to understand, but then you are left with a lack of knowledge about which systems they're using to support that.
Thank you, Francis. Go ahead, Dr. Ram Raju, please.
Thank you very, very much. It's extremely informative and a tremendous amount of information. And I thank you for doing this. I just put it in a chat box. I'm a surgeon, and I sit on the board of Federation of State Medical Boards of the United States, and involved in medical regulation over 20 years. So the issue is, I'm also a social epidemiologist, and I believe that a large portion of the diseases are constructed by the social factors, which also to be taken into consideration as we do the biological factor. So when we did the DDS system, we focused purely on disease caused by biological fact, and we basically trained the doctors on that. So now we have a greatest opportunity in the world that as we incorporate the biology and the sociology together to train them, so the decision-making systems we should do in AI should incorporate both, so that the physicians are able to take care of the biology of the disease as well as social things which contribute to the disease as a part of it, like food insecurity, pollution, climate change. All those things play a big role in that. So I just want a plea saying that as we're developing this, please take it into consideration. Let's not make the same mistake we made many years ago, purely looking at biology and forgetting the sociology of that. Thank you.
Thank you, Dr. Ram. Thank you. We have also a question in the chat from Sanjeev Garg. Please guide which AI tools are best for ANT consultants for more knowledge point of view. Regards, Dr. Sanjeev. Can you answer this, Dr. Neeraj? About what's the best AI tool? This is a very common question that everyone is asking.
So I'm not an ENT surgeon by training. I'm a radiologist. So there's one point I did want to bring up when we were designing the AI literacy modules for our postgraduates, is we were designing a blanket basic fundamental AI system for everyone to have an understanding of why is AI booming now, what goes into developing an AI in terms of networks, the data in, like we say, garbage in, garbage out, good data in, good data out, and then the securities, because these will apply to all doctors. And what we're also recommending, as I mentioned, we have 15 colleges under our Academy of Medicine, such as College of Surgeons, College of Orthopedic Surgeons, physicians, pediatricians, radiologists, etc. is we encourage each college to develop their own specialty related or specialty focus AI course, because how AI is used in each specialty is also very different and can have unique. So there is that fundamental about AI as a whole, which applies to every healthcare provider. And then there's also which parts of AI are changing or creating waves in their individual practices. For example, a gastroenterologist who does a lot of endoscopies, upper endoscopies or lower endoscopies, colonoscopies, there are AI tools for them to help them detect polyps, which they should take a biopsy of, etc. So these would not be something which is not very general, which not every doctor would know. It would be related to that specialty. So Dr. Garg, I think the only suggestion I have for your answer is if you have someone who is a bit more interested in AI developments in the ENT field that may be using AI in their practice, and it might be good to speak to them.
Thank you, Dr. Neeraj. We have also received some from Dan Harris. Please, can you share your thought, Dan? Dan is one member of our AI working group, so he's one of the most acting working group. Please, can you
Thanks
share
very
it
much.
with?
Thanks
Yeah.
very much, Muhannad, and thanks very much, Francis and David. It's good to hear your reflections on this, Neeraj too. I suppose I was just bringing in this view that we know that there are concerns raised, not infrequently, that depending on how AI tools are adopted and used across the wider health and care system, they could negatively impact existing health and social inequalities. And so I think that the perspective, Ram, that you mentioned, I think is helpful here, and one for particularly developers and clinicians who are choosing to adopt these tools to bear in mind and look for tools which actively work to improve and close down and reduce those inequalities, as opposed to using data sets which we know could reflect those existing biases and have a more serious impact. So I suppose it was just my reflection on your reflection, really, that I think it's something that would seem to be most relevant for developers as they're using those tools, and then for clinicians to consider that perspective when they're choosing from the array of different tools out there.
Thank you, Dan. Thank you so much. I'd like to come back to you, Francis, regarding to your presentation. You have mentioned something about the understanding of the risks. Do they mention anything related to the risks related to use of AI specifically they knew about, or?
Yeah. So within the survey, we asked to what extent they agree they understand the risk presented, but then the next question is, what is their actual understanding of the risks? I think it was the interviews that helped us to get underneath that more, and I think I mentioned kind of the risks that the data that AI is based on being kind of false or biased, and the importance of checking sources, and yes, the risk that the outputs could be kind of false and inaccurate. And I think the example I mentioned there was one around melanoma imaging, and that not being sufficiently trained for individuals with different skin types. But yeah, and I think we've touched on kind of transparency and clarity, confidentiality and security risks, and then consent and the risk of over-reliance. Those are the things that came through from the interviews that kind of backed up what their understanding of the broad areas of risk would be.
Thank you, Francis. And for you, David, have you mentioned anything in your recommendation about the teaching or education related to the AI literacy?
So there are references, I think, in our education standards to the use of new technologies, including AI. I mean, I think the key point is, at the moment there is a program of work within the GMC to review to review the suite of education standards and outcomes that we provide, and as a part of that, we're considering how that might be affected by the use of AI. So that's something that's very much under consideration at the moment.
Thank you so much, David. So I think I have, while we don't have extra question, I have one question to Neeraj. Thank you, Dan. Thank you. Dan just shared us with the link regarding to the AI innovative technologies question and answers. Thank you so much, Dan. So I'd like to ask you, Neeraj. We have seen something through the presentation about the eroding professional autonomy while using the AI. What do you think about it?
So thank you, Muhannad, for a question. So I think there is some concern around this because studies have been done about radiologists of different levels of experience who try to use AI for DDS systems. For example, whether they see a tumor on a breast mammogram or whether they see a brain bleed on a CT brain, etc. And one thing that repeatedly comes up is something called the automation bias. That means you start ending up trusting the AI more and more when it's given you right answers all along. And then sometimes when you have a difference of opinion, you still end up trusting the AI. And that was in fact found across different levels of experience. So we noted that in publications that have been published in radiology journals, junior doctors were quite likely to have automation bias because they would feel that they don't have the degree of experience or training, and that maybe the AI might be right more than them, even though they were actually right and the AI was having a false result. For the experienced doctors, they had the competency and ability to say that AI was not correct, but what they reported was a slowdown in their work because they saw AI having a different opinion, and where sometimes they would just quickly have a look at it and give their opinion and move on to the next case. They found themselves pausing, looking back at it again, thinking about whether they might be the ones that may have be on the erring side and the AI might be right. And then they eventually are more likely to go back and follow with their experience that they will say, okay, the AI is wrong. So this automation bias factor is going to come in, but I think it is going to be something that we as healthcare providers will learn to work with over the years when we move along. So if we have a lot of new apps or devices that come along, there's always a learning curve. There's always a little bit of, okay, what do I get used to it? I think we'll have that phase where we learn to work with AI, and we might have to navigate this automation bias journey, but we will come to eventually be better healthcare providers and more efficient when this has become more mainstream. So autonomy is a concern, and there will be this phase where we will have it challenged up and down, but I believe we will rise and come out on the other side where we will come out to use AI for the better, for providing more efficient healthcare.
Thank you so much, Neeraj. Thank you. And we will do it, Sanjeev. We will share with you all the discussions, Zooms, links related to the next topics. I'd like to thank everyone for our very rich discussion for today's session. Today's conversation has demonstrated that although healthcare system differ across jurisdictions, many of the regulatory questions surrounding the AI are remarkably similar. Three themes stand out for me. First one, AI is no longer a future consideration. It's already influencing clinical practices, healthcare, safety, public trust, and so on. Second, despite the advances in technology, professional accountability remains with the clinician. So we have to make a clear guidance and education more than ever, more than before. Today is the needs for this one is more important than ever. Finally, today's discussion has reinforced the importance of the role of regulators that can play in supporting innovation while maintaining patient safety and public confidence. And finally, on behalf of IAMRA, I'd like to sincerely thank Francis Leng and David Winks for sharing this research and policy context behind it. I'd like to thank Neeraj Mahboobani for his thoughtful reflection as our reactor, Paul as our executive directors of IAMRA, Sarah as an operation director at IAMRA, for their great preparation, cooperation to hold this session up, and all of you for your valuable contribution. And before we conclude, I'd like to remind everyone that our next IAMRA webinar will take place in September, and it will be about determining cross-border equivalency, medical education and training for perspective. We also look forward to welcoming many of you to the 17th International Conference on Medical Regulation, which will be held in Hong Kong from the 1st to the 4th of September 2027. Thank you all once again for joining us today, and I wish you all Wonderful day, afternoon, or evening, wherever you are in the world. Thank you so much.